Please, sir. Starts.
Good evening and welcome to Regain PG Renal Classroom. This is session 15 and we have been waited with bated breath when this particular class shall start again in this particular financial year. And we are very happy to have a very revered Dr. Pratik Das amongst us. He is our course director for this entire session. Let me have the privilege of introducing Dr. Pratik Das. I know he doesn't require any introduction to all of us. However, Dr. Pratik Das is a distinguished nephrologist with over 2 decades of experience in renal transplantation, specializing in kidney transplantation, including ABO and HLA incompatible transplants. He has performed over 4,000 kidney transplants and is a dedicated educator in nephrology and dialysis technician training. His specialization is in transplant immunology and HLA incompatible kidney transplantation, ABO incompatible kidney transplantation, and post-transplant infections. Dr. Das has done, as I told you, that he has done almost 4,000 kidney transplants, and he has been awarded with the Bansal Award for Young Nephrologist in 2010. He is a fellow of American Society of Nephrology, and he is also a fellow of Indian Society of Nephrology. He has published many articles in national and international journals. His professional affiliations is his executive council member of Indian Society of Organ Transplantation, executive council member of Indian Society of Nephrology. He is secretary of Indian Society of Nephrology Eastern Zone, and he was also organizing secretary of ISOT 2023. In his current capacity, his clinical practice is he is chief consultant nephrologist in NHRT-IICS Kolkata, and he is also medical director and chief of Kolkata Kidney Institute. So I welcome you, sir, for this session, and thank you very much for giving us the opportunity to have you amongst us, all of us. So over to you, sir.
So thank you very much for this nice introduction. We are in the 15th class today, and this time we'll be discussing a transplantation case. And after that, there will be, as usual, there's a OSCE session, and Dr. Anirudh will be showing some questions, so giving some questions on genetics. So without wasting time, we can start with our student, Dr. Ajitesh Singh, who is an DNB nephrology third year PGT and resident, and probably exam going in the next year, and in the Lokmanya Tilak Municipal Medical College in Mumbai. He will be presenting the case, so we can start the presentation.
Good evening, sir. Sir, I'll be sharing my screen. Sir, am I visible?
Yes, yes.
Sir, yeah, good evening, sir. So I'll be starting now. I'm presenting the case of patient AM, who is 28 years old male. He's a resident of Dombivli, Mumbai, and he is educated till class 12 and currently unemployed. He's Hindu by religion and non-vegetarian by diet. Chief complaints, he presented with the chief complaints of loose stools for 1 day, sir, for 1 week. 1 week back, he presented for loose stool of 1 day, 2 to 3 episodes, and fever for 4 days. History of presenting illness, patient presented with the chief complaints of Patient present with the chief complaints of loose stool 3 to 4 episodes, 7 days back, but watery inconsistency, not mixed with blood or mucus, which resolved spontaneously. There was no episodes of vomiting, pain in abdomen, fever during that diarrhea episode. Patient again experienced 2 to 3 episodes of loose stool, nausea, 2 episodes of vomiting, which was yellowish, non-bloody, non-bilious, 3 days back, not associated with the blood, mucus, associated with the high-grade fever, and multiple episodes of vomiting. Patient was admitted for the same and received IV antibiotics, after which fever subsided. There is no history of abdominal pain, no dysuria, no hematuria, no headache, no rash, no history of on admission. He had a BP of 108 by 60 millimeters of mercury and was told to withhold antihypertensive medications. And he had a serum creatinine of 2.5 mg per dl at presentation. Past history: patient was apparently all right till March 2024 when he experienced giddiness and headache and was diagnosed to have hypertension with a systolic blood pressure of 180 millimeters of mercury and was informed about the raised serum creatinine. Values were not recalled. He was started on tablet amlodipine and was later referred to a nephrologist, where he was worked up and diagnosed to have bilateral small kidneys. The serum creatinine was 3 milligrams per deciliter in April 2024. He was not advised for renal biopsy and he was not advised for any special blood investigation also. He was advised for dietary restrictions and some oral medications were prescribed. And there was no history of edema at that time, no history of frothyuria, no history of cola colored urine, hematuria, renal calculus, recurrent UTI, recurrent childhood sickness, no history of recurrent childhood admission, no history of chronic NSAID or alternative medication use. Patient did not have anemia at the time when he was diagnosed with CKD. Gradually, the patient started having bilateral pedal edema in May 2024, which progressed to periorbital edema. He was given medication by nephrologist, however, the symptom persisted. He gradually had reduced urine output and loss of appetite, nausea, generalized weakness over 2 to 3 months of duration. And patient also had the blood blurring of vision in June 2024 with the rising creatinine on the follow-up. Patient was admitted in our hospital with the above complaints. His creatinine was 11 milligram per deciliter at that time. Fundus was done, evaluated, which was normal, with urine output of 800 cc per day. Dyspnea on exertion, bilateral pedal edema, and persistent nausea. He was initiated on hemodialysis on the subsequent day by the right IJB catheter, and he received 2 sessions, followed with which he was discharged on the right IJB catheter and advised for 3 sessions of hemodialysis per week, which patient continued. He was also advised for ABF creation. Patient was also advised for TCC insertion, but he refused because of the financial constraints. At that time, patient and the relative were counseled for renal transplantation. And meanwhile, AV fistula was created in the July 2024. Patient was continued taking maintenance dialysis via right IGV catheter and had dry weight of 49 kilograms, intradialytic weight gain of 2 to 3 kgs, residual urine output of around 500 ml per day, no episodes of intradialytic hypertension or any other complications. And meanwhile, he developed chills on the hemodialysis, after which the right IGV catheter was removed and a new right IGV catheter was inserted after 2 days. No blood culture was sent and he was given IV antibiotics. No history of femoral catheterization or blood transfusion. And left proximal AV fistula became functional after around 40 days of creation, and hemodialysis was continued via AV fistula and right IGV catheter was removed. For renal transplantation, father came forward as a donor with the age of 51 with no known comorbidities. Several blood investigations, including HLA matching, was done, but HLA match was not recalled by the patient. Blood group is B positive for both patient and the donor. CT scan, 2D echo, USG, all were done and they were normal. During this period, patient was on amlodipine and received injection, EPO, and erythropoietin and iron supplements weekly. And patient was planned for renal transplant on 26th of Feb 2025. Patient was started on tacrolimus 3 mg twice a day, and amlodipine was continued. He received hemodialysis 1 day prior to the transplant. Injection graflon was procured and given intraoperatively, and after 2 days also. And he had reduced urine output post transplantation, but serum creatinine was not recalled, and he received hemodialysis on the next day of the surgery. Capsule tacrolimus, MMF, and prednisolone were given post-op along with the oral medication. Transplant renal kidney biopsy was done after 3 to 4 days, and patient does not remember the report of it, but he received 2 sessions of hemodialysis post-op, and hemodialysis was stopped after 1 week. Foley's catheter removal was done after 10 days. Serum creatinine was again rising, so a repeat renal biopsy was also done after 15 to 20 days. He did not have reduced urine output at the time, no graft tenderness, no fever, urine and blood investigations were not recalled. Post biopsy results, he was given MPS for 3 doses, and along with that, plasmapheresis was given, and some expensive injection was given. 3 sessions of alternate day plaques was given, and which was stopped due to the financial limitations. After this, the patient's creatinine was stable, became stable, and remained around 1.6 milligram per deciliter. DJ stent was removed after 1.5 months of the transplant. Patient had also swelling in the scrotum post-transplant, for which surgical opinion was taken and advised conservative management and scrotal support. But the swelling did not subside for 2 to 3 months, and so surgery was done for that. During follow-up, patient was compliant to the medication, required single antihypertensive with well-controlled BP. Patient's ABF stopped 3 to 4 months post-transplant, and the serum creatinine remained stable. On routine evaluation, patient once developed rising creatinine 7 month post-transplantation, for which he was admitted. There was no reduced urine output, no graft pain, no frothy urine, no hematuria, received IV fluids, and tacrolimus level were normal for the age of the transplant, and the renal biopsy was done, but the report again is not recalled by the patient, but the creatinine came back to the previous level after the treatment, and there was no history of MPS or any other expensive drug given in that admission. After this, the patient's creatinine remained stable and the patient was compliant to the medication, but now presented with the above mentioned chief complaints. Course during current hospitalization, relevant blood investigations were sent, stool and urine sample were collected, TAC level were sent, managed with IV fluids and some medications, and no diarrhea or fever during admission, gradual improvement in the renal function, no changes in the drug dose or history of giving MPS. Serum creatinine gradually declined to 1.7 milligram per deciliter. Personal history, he has no history of addiction, normal bladder bowel habitus, vegetarian white diet, no history of blood transfusion, no significant family history in any family member. Summary: a 28-year-old male who was known case of hypertension, CKD, native kidney disease not known, initiated on maintenance hemodialysis, underwent renal transplant after dialysis, vintage of 8 months, live-related donor compatible, donor for the HLA mismatch not known, and delayed graft function for requiring hemodialysis for 1 week post-transplantation, episode of ABMR 20 to 30 days back, 30 days after transplantation, which was treated with MPS, plaques, and injection query likely to be IVIG or rituximab with the complication of hydrocele or lymphocyte, which was surgically repaired with the history of acute graft dysfunction, currently presented with the complaints of loose stools, fever episode, and graft dysfunction with hypertension. Sir, should I continue with the examination, sir?
Okay, in the history, you should highlight the points which are important because you have to identify the problems, and then as a doctor you can treat the patient accordingly. Okay.
Yes, sir. So in the current history, the patient presented with the episodes of loose motion, which happened 7 days back, and then it was okay. And then after 3, 4 days, again loose motions with the vomiting and the fever episode was there. And he has a history of delayed graft function along with the uh, antibody-mediated rejection
Okay.
and history of renal biopsy 3 times.
So if suppose a patient in the post-transplant comes to your OPD and with this history of this loose motion or loose stool for sometimes along with fever, so what is your approach actually in this kind of patients?
Sir, for the patient
Kind
with
of
the
history will take additionally and how will react?
yes, sir.
What additional history will you take from the patient?
Sir, any history of uh, eating habits, whether the patient is having hygienic food or not, because the patient present with the loose motions and the vomiting episode along with the fever.
Okay, so have you asked for what has been taken in the food? Whether other
Yes, sir,
family members
he
have the
takes
same,
well cooked food, home based only.
whether the other family members are affected in the similar way or not?
Yes, sir. No similar any no family member had suffered any episode of gastroenteritis during the same time or any fever episode in any family member.
What about this water intake? What kind of water he is taking? Is a corporation supply water? Is a boiled water? Is a
Sir,
underground water?
rest of the family member are taking sir RO based water in the home, but for our patient, he brings Bisleri bottle for himself.
So it takes some treated water.
Yes, sir.
What is the water supply source in Mumbai?
It's a municipal.
What is the source? Suppose in different countries, some saves the rainwater and they serve some from the river, like
So
Calcutta.
there is a dam which stores the water.
Okay. So, uh, so you have to take the history, what kind of water he is taking, because you are thinking of some infections. Okay.
Yes, sir.
So while discharging a patient for after transplantation, how will you counsel the patient regarding water intake, hygienic water intake?
Sir, a patient has to be counseled about the food and water habits that all the cooking, he should be taking only cooked food, raw food should not be taken. And the person whosoever cooks should be uh, following all the hygiene, hand hygienes. And also the water should be purified, preferably if boiled, that will be better.
So purified and boiled. If you ask him to boil, how much is a what is the time for boiling and how they will preserve in the bottle and what kind of bottle you will prescribe?
Uh, so the patient should have a boiling. So I don't know, sir.
Boiling kills what?
Sorry,
Suppose
sir.
in 100 degrees Celsius temperature, what are the
Yes,
things that has been killed? Normal all bacteria, including viruses, they are killed.
yes, sir.
Okay, so we have to boil it for 20 minutes. And
Yes,
after
sir.
that, you cool it and then put in a bottle which is a wide mouth so that this can be cleaned time to time. Every time it is not possible to purchase this bottled water and this.
Yes, sir.
Okay, the source of water is important. Okay, if the
Yes,
patient is taking an underground water that is more of a mineral, less of bacteria, the surface water, more of bacteria, less of mineral. So that is
yes, sir.
important. Other family members are also important.
Yes,
Okay,
sir.
but this patient you were thinking of, he suffered from some infective causes of diarrhea.
Uh, yes, sir. Because the patient also had fever episode,
Okay.
so more likely to be some acute infection.
So, what may be the other causes of this loose stool during admission? Suppose in any transplant patient having a diarrhea in the post-transplant period, and
Yes, sir.
what are things will you think?
Sir, it may be drug induced because the patient is on a standard triple immunosuppression, that is tacrolimus, steroid, and also mycophenolate mofetil. So mycophenolate mofetil is known to cause GI disturbance along with the diarrhea episodes.
So, are you aware of any guideline which says that diarrhea should be interrogated or intervened in a patterned manner? Are you aware of any trial?
No, sir.
Are you aware of a trial called a DIDAC trial?
Yes, sir. Sir, it was discussed, but
Okay,
I'm
this is
not
for the
not
diarrhea
recalling.
patients, not for your kind of patient. This is particularly at least a 7 days diarrhea, 4 times a week, 4 times a day loose stool, watery diarrhea. They have asked that you have to look after the in the step one for the non-immunosuppressive drugs. Suppose the patient is getting domperidone, facing the etopride and the laxatives and some antiarrhythmic drugs. So these things would be looked for non-immunosuppressant. If it is okay, you stop those drugs if it is possible. Then you go to the second one. They ask for the infections like bacterial infection. We have searched bacterial infections or the fungal infections. And the third step, if it is not controlled with this antibiotic, your patient is controlled. You go for viruses. If it is viruses, you have to look after. And are you aware which kind of viruses that affects and cause diarrhea in a post-transplantation?
Sir, wide essays.
Virus. Name some viruses.
Viruses, yes, yes, sir, yes, sir. Sir, various viruses can affect and cause the GI disturbance along with the presentation like this, and the patient may have,
Some viruses.
sir, patient may have CMV, colitis. Patient may have norovirus infection, and even if any patient may have immunosuppression, uh, like HIV can also present with the diarrhea like episodes.
It can be enterovirus, it can be rotavirus, norovirus. This
Adenovirus, yes, sir.
third step is your virus. Fourth
Yes,
step,
sir.
This kind of virus is excluded by your test, then you have to look for any whether any blind loops are there or not, any bacterial colonization in the gut. Then in the still you have to treat them because antibiotics are there. The next step you go for, just read it. You have to
Yes,
go for the next step to look after the colonoscopy and take a biopsy.
yes, sir.
Yes. What kind of diseases can be diagnosed by biopsy? Colonoscopy
Uh,
biopsy.
Sir, inflammatory on the biopsy, we
Depend
can
in
look.
post-transplant state.
Yes, sir. So in the biopsy, we can diagnose the patient with the inflammatory diseases, which may be flaring up due to
Suppose
the
at 8
immunosuppression.
years, an adult patient having a refractory diarrhea, you have excluded the infection, you have treated with antibiotic, you have altered immunosuppression, still that this is not improving. So what kind
So
of
inflammatory bowel disease, it can be, and it could be for our
relevant
patient,
for a transplant patient?
PTLD, sir, can be presenting like that
You have to
post.
look. Adult PTLD presents like this GI, this may be diarrhea, this may be melena, this may be. So these things are very important. You have to look. It is not like children who develop a lymphadenopathy.
Yes,
Okay.
sir.
Once you exclude these also in a colonoscopy and biopsy, then you can adjust with your immunosuppressive drugs, like you have told mycophenolate. Okay.
Yes, sir.
So why
Yes.
mycophenolate causes diarrhea?
Um, Sir, mycophenolate mycophenolate mofetil leads to the anti-proliferative effects, which leads to the decreased gut. Uh, it inhibits the uh, IMH.
So there are
Uh,
some cells which
yes,
proliferate very fast in the body. There are some
yes,
cells which do not proliferate at all, like your brain cells, your kidney cells, but your intestinal epithelium, the highest circulating, almost near to the hematology system, there is a cycle is very fast. So
yes,
if
sir.
you prevent the DNA formation of those cells, they will not be circulate.
Yes, sir.
The possibility of diarrhea.
Yes,
Okay.
sir.
So for that, some modification of mycophenolate has developed.
Yes, sir.
Which
Sir, normal mycophenolic acid that we use is replaced by mycophenolate sodium that leads to decreased GI irritation and as well as decreased diarrhea episodes.
So why it is high in the mycophenolate mofetil and high but it is less in mycophenolate sodium?
Uh, Sir,
It is a controlled release one.
yeah,
Okay,
yes, sir. It is controlled release one. Yes,
control.
sir.
So you are concerned about the small intestinal epithelium. That is the highest turnover, not the
Yes, sir.
colonic epithelium.
Yes, sir.
They are controlled release. They're released in the terminal ileum or the late jejunum. So the chances of diarrhea becomes less, but practically studies have shown there is hardly any difference. Okay.
Yes, sir.
So I am emphasizing on this point because there is a common mistake from our side that we first stop the mycophenolate as there is any diarrhea. But this
Yes,
should
sir.
not be. You have to be in a stepwise manner. That will give you a better result for a diarrhea patient.
Yes,
Okay.
sir.
So this patient developed diarrhea and is a 1 day fever and there are some graft dysfunction.
Yes, sir.
So what is the cause of the graft dysfunction in the recent admission? What do you think?
Sir, in the recent admission, the patient is having graft dysfunction and he presented with the hypotension and he had volume loss in the form of diarrhea as well as the vomiting episode. So, my first impression would be that it is more likely to be pre-renal effect. Pre-renal AKI should be affecting the graft function.
So how much blood pressure is needed to maintain a renal blood flow in a transplant patient? So what is the mean arterial pressure that is essential to maintain the renal blood flow?
So, 65 millimeters of mercury of MAP is enough to
At least it should
maintain.
be 65. Yeah, above this is okay, more than 100 is fine, but it should be at least. But in your pressure, you have mentioned a blood pressure of 108 by.
60.
So what is the mean arterial pressure for this patient?
60 into 2 by 3, 40.
You just tell how do you calculate, then other people will calculate.
Yes, sir. Sir, it would be 1/3 of the systolic blood pressure plus 2/3 of the diastolic blood pressure. That will lead to the mean arterial pressure.
Is it like that or something? Some else, other formulas are there. Read it. Okay. So for
Yes,
this question, we were thinking of a pre-renal one.
yes,
So
sir.
in a pre-renal one, this is renal local nervous system plays an important role. Even in a normal kidney, without any hypotension in a sepsis patient, you can get a pre-renal AKI. So how does a transplant kidney hypotension and the pre-renal AKI differs from a native kidney pre-renal AKI?
Sir, in a transplanted kidney, when compared with the native kidney, there is no local network of the the transplanted kidney is denervated, and there is no local milieu for the kidney to which helps to maintain the
So they
uh,
are more prone to, there is no protective mechanism. This is
yes,
DNR. You anastomose the artery, you anastomose the vein, you don't anastomose the nerves. So
yes, sir.
they are more prone to develop the pre-renal AKI. So
Yes, sir.
this patient has probably developed that. You are given some fluids and some antibiotics, and this patient is improved.
Yes, sir.
Hmm?
Yes,
Okay.
sir.
So, so for this episode, the important thing is that you are concerned about the diarrhea. This is not a diarrhea; it's a loose stool for a 1 day, and frequency you have not mentioned how much. Uh,
Sir, 2 to 3 times per day.
okay.
Only for one day
What are
initially, and then
definition of
another
diarrhea?
episode.
Definition of diarrhea.
Sir, more than two episodes per day with
You don't
the change in
average
the
that
consist with
patient
the change
goes
in the consistency of the stools.
2 times. Average almost 80% Indians have 2 stools a day. Yeah, one before going to office, after coming from office. Okay.
Yes,
So this patient now, this time the patient has got some loose motions. He has dehydrated considerably. He has a pre-renal AKI, and you have treated, and now the patient has become stable. Okay.
yes,
But your best creatinine is around 1.7 now on discharge.
yes, sir.
Hmm?
Yes, sir. Sir, the best creatinine after transplantation for him was around 1.5, and now he was discharged on 1.7.
1.7. So this immediate episode is a 2.5 episode due to diarrhea. Just going one step back. Is
Yes.
1.7 creatinine. What may be the cause of this 1.7 creatinine in 7 months post-transplantation period in this live related transplantation?
Sir, the patient initially suffered delayed graft function, which and also had ABMR episode, and also history of AKI episode in the past, during which the biopsy was also done.
Ask for any reason. If you get an 1.7 creatinine at 7 months of the post-transplantation and with a relatively asymptomatic state, no reversible causes as of in the surroundings other than this diarrhea, then what may be the causes?
So patient may have um, uh, re, re, recurrent disease, which may presenting in the form of renal dysfunction.
It's a recurrent disease. So in a 7 months period, if you think of a recurrent disease, what kind of recurrent disease will you think?
Sir, patient may have the atypical HUS or TMA
So
like presentation.
what is the nature of recurrence of atypical HUS and TMA? How do they recur?
Um,
Put a timeline of recurrence of the disease in a post-transplantation period in which part? Suppose first 1 month, then 1 month to 1 year time, and more than 1 year, more than 5 years. If you put in that way, can you name some recurrent diseases? Then you can
Sir,
think of what has happened for this patient.
yes, sir. Sir, FSGS may present on table.
Atypical HS, if it recurs, when it does it recur?
So atypical HUS may present within 6 months of transplantation.
It is almost immediate. It recurs
Yes, sir.
immediately. It causes a graft dysfunction of varying degree. Graft loss is very common. Immediate. Okay, so at the best, it should be within 1 month period or 2 months period if you don't treat and identify.
Yes,
So
sir.
it is probably not the case in your scenario.
Yes, sir.
What else? What other
Uh,
recurrences you will think of?
Sir, uh, FSGS may present on table in the patient, and this AHUS can present within 1 month, and also there is very high
FSGS can
chance.
present at 7 months post-transplantation period.
Sir, FSGS may present from table, sir, at the table to any time. It can
Anytime.
present.
It can
Yes, sir.
present on the table, it can relapse on the table, it can be at 6 months, at 1 year, and 5 year, whatever may be.
Yes, sir.
Okay. So, do you think it is a FSGS recurrence?
No, sir. Sir, it is not typical presentation of FSGS.
Then what is the typical presentation of FSGS?
Sir, FSGS will present more with the complaints of proteinuria and edema might be there, and not so AKI episode might be as a consequence of
Consider is
FSGS.
pre-transplantation course. Does it give any idea? There is no biopsy done for the native kidney.
Yes, sir. Yes, sir.
Does it give any idea about this? What kind of uh, patient they have more chance
The
of recurrence?
patient uh, in 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 the pre-transplant period, patient did not have any features other than hypertension that might be suggestive of glomerulonephritis, but more likely to be CTID, other than the fact that he did not have anemia.
Patient had hypertension.
Yes, sir.
So you were not thinking of FSGS. I'm not going to detail. So what may be the cause of this 1.7 creatinine recurrence, not HUS recurrence, not FSGS recurrence? Anything other? Can you name some 2 or 3 diseases which also is notorious for recurrence?
Mm, mm,
Hmm?
no, sir.
Anything MPGN, DDD, C3
Yes,
glomerulopathy?
yes, sir.
No, they recur.
Yes, sir.
Yes. So there is a possibility membranous do the recur. IgA nephropathy do the recur.
Yes, sir.
So you have to name them, na? So will you think it's a IgA nephropathy because a native disease can always be an IgA nephropathy?
Yes, sir.
Hmm? Yes, but I'm
Uh,
not thinking why.
mm. So the patient did not have any history of hematuria. There was no history of hypertension in the post-transplant period.
So they do recur early or late.
So IgA presence, recurrent IgA presence early and de novo IgA presence late.
So recurrence is also late. Okay.
Yes,
And do they cause graft dysfunction very often? No.
uh, yes, sir.
Okay.
No. Yes, sir.
So probably you are not. This is not your case. Is not a recurrence case.
Yes, sir.
Could have discussed in detail, but it doesn't appear. So if you get a patient with a 7 months 1.7 creatinine, and if you want to, you have to go by the some either by some records or by some paper or some document that it should be like this only. So at your preference, what can be the first probability? What can be the second probability? What can be the third probability?
So for 1.7 creatinine in his case, uh, my first probability would be, sir, any immediate surgical, if there was any uh, issue with the graft itself in the form, sir, I forgot to mention his cold ischemia time, which was around 200 minutes.
We'll go
So,
that. We are going back from the present to the past. We'll go back to that also.
yes, sir.
Okay.
Uh,
So do you think it is a what do you think for this patient? If you do a biopsy, what will you get?
So in the biopsy, we first of all we will get acute tubular injury.
Why acute tubular injury for the recent episode of diarrhea?
Uh, no, sir. Sir, the graft dysfunction was uh, graft dysfunction is
Seven
there.
months post transplant.
Yes, sir.
It is 7 months post transplant, so you cannot think anything about immediate post operative. So acute tubular necrosis is unlikely, no?
Yes, sir.
If suppose this patient has a delayed graft function in that at the time of transplantation, and that time ATN happened, and if you do the biopsy now in at 7 months, what will you get?
Sir, there will be chances of interstitial fibrosis and tubular atrophy
Yes.
because
So you will be get an IFTA, that is interstitial fibrosis and tubular atrophy. That you will get. You will not get ATN for this patient.
yes, sir.
Okay. So are you thinking of this patient will biopsy will show only the IFTA?
Sir, there is patient is also having on the immunosuppression tacrolimus, so there
What
is
are the
also
points? But this patient might have an only biopsy might show. What are the causes of this graft dysfunction if you correlate with the earlier events?
sorry, sir.
What might be
Biopsy.
the cause of this graft dysfunction if you correlate with his history?
Um, Sir, patient has had episode of graft dysfunction previously also and had increased cold ischemia time. So if TA would be there and also uh,
So graft
uh,
dysfunction you will see in the IFTA, and you are thinking of this is a sequelae of the either ATN or can be IFTA is a sequelae of what? One is acute tubular necrosis, another one is in a transplant kidney,
TCMR.
TCMR. So they are always overlapping.
Yes,
Okay,
sir.
ATN predisposes the TCMR, they exposes the epitopes on the surface and precipitates rejection. So this is a
Yes,
possibility. They has a delayed graft function as a ATN, probably has an ACR also at the same time, and now has developed. This is the one possibility has developed IFTA and CKD basically.
yes.
Okay. Now, and next, what is the possibility?
Sir, next possibility is acute uh, tacrolimus toxicity.
Acute tacrolimus toxicity. What are the acute tacrolimus toxicity? 7 months post transplantation.
So the
Just name
patient,
first what are the tacrolimus toxicity and put it in this for this patient.
uh, sir, tacrolimus toxicity on histo, you are asking?
So any tacrolimus, you are a clinician, you are not a pathologist.
Yes, sir. So,
Hmm.
tacrolimus toxicity will present with the accelerated hypertension. Patient may present with that. Patient may have neurological feature. Patient may have uncontrolled sugars on presentation, on clinical examination. Also, they present with the tremors.
So what happens to the kidney? Forget
Uh,
about extrarenal side effects. I am asking about renal side effects of tacrolimus.
yes,
Immediate,
sir.
early, late. Tell, just enumerate.
Sir, tacrolimus present leads to the pre-renal AKI by causing the vasoconstriction, efferent vasoconstriction.
Yes, so you have to tell that. It happens to all patients. Whenever you give this CNI, that will be a vasoconstriction. There's a transient drop in urine, might be a slight rise in creatinine. It happens to everyone. If
Yes,
you
sir.
give in a mannered way, at a definite dosage, then it will happen less. If you give at a higher dose, it will happen more.
Yes,
Okay,
sir.
so this is apparent arterial constriction, and then other
So, in,
early side effects. Classically, what you were telling is an acute CNI toxicity. It affects
yes,
which part of the kidney?
sir, it affects the tubules.
Yes, it affects the tubules. Okay, in the tubules, what will you get if you do a biopsy for this patient?
Uh, sir,
Okay, it can cause a vacuolization of the epithelium.
yes, sir.
Na? So,
Acute tubular vacuolization it causes. Yes, sir.
vacuolization in the same way. What else happens acutely for CNI toxicity?
Sir, classical literature, sir, tubular vacuolization, it says, and in chronic long-standing state, there will be hyalinosis.
So arterial hyalinosis, and there may be a stripped fibrosis. We call it a stripped fibrosis, a band like fibrosis.
Yes, sir.
Because your one arteriole get constricted for a long period of time and gives the area supplied by it get fibrosed.
Yes, sir.
Okay, so you will not get the initial part which you have told. You will get this art if you biopsy for this patient and think of CNI toxicity at all, then you will get this chronic CNI toxicity. That can be one possibility for this patient. But you have
Yes,
told the CNI levels are okay.
yes, sir.
Okay, so you are also not thinking. You are not thinking of recurrence of a disease. You are not thinking of a CNI toxicity for such patient. So what
Yes,
are
sir.
you thinking actually for the graft
Uh,
disease? Another side effect we didn't told is a TMA. That is also an acute side effects of
uh,
CNS.
CNI, yes. Sir, and patient may have infective cause like CMA colitis.
One day diarrhea that too has resolved with your simple measures.
Yes, sir. Less likely.
Less likely. So do CMV cause a graft dysfunction?
Um, Sir, CMB may present with the nephropathy, but the course will be
How do
prolonged.
CMV can cause a graft dysfunction?
Yes, sir.
CMV per se doesn't cause a graft dysfunction, but it can precipitate ABMR.
Yes, sir.
Is it true?
Uh, CMB, sir.
Yes.
CMB may, yes, sir.
So it can always, there is a virus crosstalk and there may be the precipitations of the ABMR. But directly per se, CMV doesn't cause an graft dysfunction. It causes so many extrarenal areas that is being involved. And very rare situation, you will get a graft dysfunction, but that is not very common.
Yes, sir.
Okay. Then which virus is more important?
So, VK virus.
So is it possible this patient has developed BK virus nephropathy now?
So BK virus nephropathy usually presents around may it start to present at around 9 to 12 months and typically presents without. Yes, sir.
Happens beyond between 3 months to 2 years time usually.
Yes,
Okay.
sir. And typically presents without any fever episodes and the gradual worsening of the graft function.
So there is a worsening of the graft function. There is
Yes.
so
It is possible to be,
is there
sir.
anything special if you think of the history of such patient? There is anything to suggest that this patient has developed a BK virus nephropathy?
Yes, sir. Episode of antibody mediated rejection itself,
What are the
and
risk
which,
factors for BK virus nephropathy?
sir, and strong immunosuppression history and prolonged this delayed graft function.
Yes, delayed graft function,
Yes, sir.
prolonged cold ischemia,
Yes, sir.
and there's requirement of dialysis post-transplant.
Yes.
Okay, and there's development of ATN. All these are very important risk factors.
Yes, sir.
Okay, if you follow 100 patients who have a delayed graft functions, among these more than 50% develop a BK virus nephropathy. In a total transplant scenario, what is the percentage of having a BK virus nephropathy and graft dysfunction? Average?
Sir, VK virus nephropathy uh, will lead to degree. Sir, um,
Graft dysfunction, it happens to be around 3 to 10% of the cases. Are you aware of any series or study? No, okay. So it is possible. This patient is a male patient, young patient, having a delayed graft function, ATN, dialysis requirement, and now at 7 months' time, he has a gradual deterioration of kidney function and it is 1.7.
yes, sir.
It is possible. Hmm?
Uh,
You
yes,
should
sir.
put it in your diagnosis. So what else? So your recurrence of disease is out. Your CNI toxicity is unlikely. Your BK
Yes.
virus nephropathy is very much on. What else?
Uh, mm,
Will you think of any, suppose 100 patients, not this patient, 100 patient of transplantation, there is a graft loss. There is a lots of controversy regarding the terminology graft loss and graft failure because there's huge psychological trauma. So new KDIGO has suggested not to use such terms. So if this happens, so what is the, can you give up some idea how this graft loss or graft failure happens in a transplant patient? What is the most important cause of graft
uh,
loss in a kidney transplant?
non-adherence to the therapy.
No. 50% patient die of other
Cardiovascular,
diseases with a function.
cardiovascular mortality.
Okay. They die of cardiovascular disease, they die of malignancy, they die of infection, and they die of so many causes. So this
Yes,
is
sir.
50%.
Yes,
So
sir.
rest your 50% you can divide in different way. It can be a infectious cause, it can be immune cause and non-immune causes, infectious causes versus non-infectious causes.
Yes, sir.
Okay, so you have to be very sure that what may be the cause of graft dysfunction. So we have discussed about the infection, and next, what else? For this patient, so many things has happened other than this delayed graft function.
Yes, sir. So the patient,
50% which loses graft with life, they are alive but still they lose graft. What is the commonest cause?
uh,
We used to call it chronic allograft nephropathy. Now we call it
neuropathy, yes, sir.
antibody mediated rejection.
Chronic antibody mediated reaction, yes, sir.
So is it
Can.
possible for this patient?
So can present late into the transplantation, but it is for post 7 month or 12 months. Post 7 month, it
What
is
is
a
the
little early for.
what is the late for a graft dysfunction and kidney transplant? What is the time cutoff?
So around more than 10 years.
10 years.
So can, yes,
Suppose
so
you are
more than
telling
six.
in your exam early graft dysfunction versus late graft dysfunction. What is the time cutoff that has been suggested? In
Uh,
6 months. Okay.
yes,
So your patient is beyond 6 months. Now you have a graft dysfunction. He is alive. You are thinking this patient had one episode you suggested probably has an antibody mediated rejection
yes, sir.
in the immediate post transplantation period. Hmm?
Yes, sir.
Why are you thinking there is an antibody mediated rejection in the immediate post transplant period?
So the patient had a very long cold ischemia time, and also at that time, uh, patient improved with the treatment which is suggestive of
Yes,
antibody
biopsy
mediated.
done. There's
Biopsy
a
was done,
treatment
but the
with
patient does not recall.
plasmapheresis. There's a treatment with IVIG probably or maybe rituximab and improved.
Yes, sir.
Okay. So now has developed. So is it possible the patient has developed a chronic antibody mediated rejection now?
Yes, sir.
Hmm?
Yes, sir. It is
What
possible.
are the ways any patient develops a chronic antibody mediated rejection? One is like yours, an acute antibody mediated or active antibody mediated rejection that is treated, partially responded, now subsequently develop a chronic antibody mediated rejection. What is the
Yes.
other way of developing a chronic antibody mediated rejection?
Uh, so non-compliance to treatment, non-compliance to immunosuppression
Not always
can also.
non-compliance. The doctors sometimes we also reduce the dose to such an
Yes,
extent that develop.
yes, sir.
So that leads to what?
Sir, antibodies, मतलब
Yes.
reduced immunosuppression, then the required will
Reduce
lead to
immunosuppression, the antibody will be developed. What is that called? It develops post-transplant.
de novo
Yes,
TS.
de novo antibodies. Okay, de novo anti-HLA antibodies.
Yes,
And
sir.
it usually develops how many months after transplantation?
Sir,
Starts from after 3 months, but it is usually more common in between 6 months to 4 years time. Okay, so it can be a de novo antibody. Which class of antibody it is? Class 1,
class
class
2.
2. Usually is a class 2 antibody, and they can precipitate a chronic splundering type of rejection that is manifested either by a rising creatinine or maybe proteinuria or both. Okay,
Yes.
so if a patient develops an active antibody mediated rejection in the early post transplantation period, are they more prone to develop a chronic antibody mediated rejection in a late transplant period?
Yes, sir.
Yes. Okay, because there is some residual damage, antibody activity might be there. But if the initial transplantation is class 1 antibody and that usually dissolves. Okay. So this patient might be on chronic antibody mediated rejection, might be active or inactive. Are you aware what is a chronic antibody mediated rejection? What is that?
So chronic antibody mediated rejection is classified as BAM category 2, and this
You have to have an antibody mediated rejection. You have to have some suggestion of chronicity.
Yes, sir.
What are the suggestion of antibody-mediated rejection and what are the suggestion of chronicity?
Sir, patient can have uh, uh, DSA. Sir, for uh, rejection part, we see glomerulitis. For antibody-mediated rejection, we see glomerulitis and peritubular capillaritis, and there may be also, sir, we'll see C4D staining.
Okay, so you have to have antibody like DSA, you have to have complement activation like C4D, you have to have some inflammation.
Yes, sir.
Okay, maybe capillaritis, maybe glomerulitis. These three things. These are the signs of antibody-mediated rejection activity.
Yes, sir.
What suggests a chronicity? What is added to this, and that becomes a thing: chronic active antibody-mediated rejection, not an active antibody-mediated rejection.
IFTA. Sir, IFTA.
Not IFTA. IFTA is a mostly is a cellular line. Ultimately, everything will be in IFTA. Two things
Uh,
in biopsy.
uh,
Something we
yes.
call it is G1,
Uh,
basement membrane multilayering. Have you heard that?
Yes, sir. Yes, sir. Multi-layering can be seen, and the glomerular basement membrane multi-layering is seen, which
So
has to be seen on electron microscopy, more than 7 layers in one.
find that
Uh,
some glomerular changes are much more, and there is a basement membrane has multilayer. That suggests there is a some amount of chronicity is set in, and
yes,
their
sir.
treatment is different. So this is possible. Another expectation for this patient at this stage. Okay. So so if you now anything else you want to tell, this is 7 months post transplantation, 1.7 creatinine and etiology is you are thinking of, you can just enumerate. Now your chronology will be what? Number one is what? Number two is what? Number three, number four, or anything you suggest? Anything else?
Sir, number one should be chronic allograft dysfunction, chronic allograft, ABMR.
ABMR. Okay, this is number one is chronic ABMR. Number two is
Uh, n- Number one, sir, actually, we can keep number one as infection, some infection leading to pre-renal.
no. This is pre. This is I am not thinking. You have treated this pre-renal part. Forget about that. You have treated and it is improved.
Yes,
Okay.
sir. So in
What
that case, sir, first should be chronic ABMR, and second should be
any
uh,
patient of chronic graft rejection develops a diarrhea that causes an renal AKI at the same time that also alters the drug pharmacology.
yes, sir,
So which drug is affected by the diarrhea?
tacrolimus.
Yes, it goes up. If you test
Yes,
normally level is 4 to 6, now it will become 10 to 12 for the time. And the diarrhea improves, it will also improve.
yes, sir.
So you don't think of an acute events. You are thinking of we have left this period. This initially you have treated that part. Okay.
Yes,
So now we are thinking of these three or four etiologies.
yes, sir.
Hmm? So
Yes.
number one is just enumerate.
Chronic ABMR, then should be the we may consider recurrent disease, which is less likely.
So number one, number two, your infection might be a BK virus nephropathy. Number three, it can be an simple IFTA or developing CKD as a consequence of ATA. Number four might be a CNI toxicity. You have to exclude the recurrent disease. Okay,
Yes,
or a de novo disease. Hmm?
yes, sir.
Are you
Yes, sir.
comfortable with this?
Yes, sir.
Yes, because that will guide you, because you have to differentiate basically two things. You are in an immunocompromised situation, or your immunity is low or immunity is high.
Yes, sir.
Suppose if we give this list and the patient's immunity is low, so what are the possibilities that comes up?
Sir,
Immunity is
chronic
high. What are
ABMR,
the possibilities comes
chronic
up?
ABMR remains on the top, sir, and possibility of de novo or recurrent disease comes up. Otherwise, BK virus goes for if where immunity is, sir.
Immunity is low. Suppose this patient is over immunosuppressed, then chances of what increases?
Uh, BK virus would be on the higher side, sir.
Yes, yes. And if then the chances of rejections will be lower.
Yes,
What
sir.
about the recurrence of the diseases? If the immunity is high, as the immunity is very low, your drug level is high, drugs are high.
If the drug level is high, then recurrent and de novo disease should be on the lower end.
Okay, okay. So you have to decide then what the patient's immunity is up and down, and accordingly you have to go for a biopsy, but at the same time you have to be very sure.
Yes, sir.
If the patient's immunity is high, then
If the patient's immunity is high, sir, then BK virus chances is less likely, and any malignancy or any other this like PTLD goes also lower possibility.
patient's immunity is very high. Well, besides the immunosuppression level is high, immunity is low. In those situations, you think of a BK virus. And what about malignancy? You are talking about PTLD. PTLD is happens in over immunosuppressed patient or under immunosuppressed patient.
Sir, over immunosuppressed patient.
So in one hand you have BKV and PTLD, in another hand you have this antibody mediated rejection or this recurrence of the diseases.
Yes,
Okay,
sir.
so you have to test them. I am not asking now. You go back further. This patient had an episode in the immediate post-transplantation period. What happened to the patient?
Uh, Sir, patient in the immediate post-transplant period, patient had a cold ischemia time of more than 200 minutes and had a delayed graft function, required 2 sessions of hemodialysis in the first week, followed by no dialysis, followed
Had
by
delayed graft function or a primary graft dysfunction?
uh, sir, it is uh, patient does not recall the immediate urine output if it was
Are you aware of the
uh,
difference between these two terminology between a delayed graft function and a primary graft dysfunction?
Sir, delayed graft function is when you have to dialyze the patient within the 7 days of the transplantation, and
Yes.
the primary graft dysfunction is when you have to when the urine output is low, immediate urine output is low post transplant.
Not that is a which one is more sinister, primary graft dysfunction. So delayed graft function is a 7 days episode, maybe may extend further. You need some dialysis initially, but ultimately many of the situation it improves. But primary graft dysfunction means thereby there is a permanent loss. In many
Yes, sir.
situations, it lands up in a graft nephrectomy. Okay. So that is different. So this patient probably had a delayed graft function.
Yes, sir.
Hmm?
Yes,
Required a
sir.
dialysis in the first 7 days period, immediate post-transplantation period. And so what may be the cause of this delayed graft function in your opinion?
So my first probability is the prolonged cholestimia time.
So why there should be a prolonged cold ischemia? Tell me what is a cold ischemia time, then you tell me why there is a prolonged cold ischemia time in the live donation, live kidney transplantation.
Prolonged cold ischemia time is
What?
defined as the time
Mhm.
after the kidney has been removed from the after the kidney has been infused with the the preservative solution or is transferred to the uh, refrigeration system and followed by until the re-anastomosis of the artery has been opened.
Suppose I am telling the sequences. There is a clamp in the donor's artery. Okay, the blood circulation is halted for the transplant for the donor kidney.
Yes, sir.
Now your time, what is that time? Now you
Warm,
take out
warm
and
ischemia time starts.
this is a warm ischemia time starts. So then you put the patient on the table and you on the ice and you start your reperfusion. No? That is a
Yes,
cold
sir.
ischemia time.
Ischemia starts. Yes, sir.
Okay, so why there is a cold ischemia time will be prolonged for a patient who is life related transplantation in a hospital like yours?
Sir, may have difficult anastomosis, may have multiple arteries, or if the patient is in rare cases like genetical cases like Marfan syndrome, may have difficult anastomosis due to the condition of the vessels, or in if any patient who is old and has atherosclerotic arteries may also have difficult anastomosis.
So this patient had a difficult anastomosis.
So patient had two arteries.
There's a two arteries. If there is a two artery, what is done actually?
So both arteries can be connected and can be directly connected to the single connection can be directly connected to the iliac vessels of the recipient.
Okay, so this can happen. So you are telling this is happening on the table, or this happens in the within the recipient bed transplant
Uh, Sir, this has to be done on the table.
on the table. So what actually is done in the transplant kidney when it is removed from the donor, and what is done in the table, and why it is done?
Sir, in case of deceased donor transplant, we can take the aorta patch of aorta along with the arteries.
We are not discussing today the disease donor. We're discussing the live donor. As your case.
Yes, sir. Sir,
What actually
in
you take out the
in
kidney.
my case, if there is some small branches there, then we can also consider ligating that branch.
So you take out the kidney and you do some reperfusion.
Yes, sir.
Hmm?
Yes, sir.
Reperfusion. Why this is done and how this is done?
Sir, the reperfusion can be done by various methods. In live-related transplant, there are in the deceased donor transplant, commercial solutions are available like STK solution, while in the live-related transplant, uh, there can be locally made solutions can be used to
So
do the perfusion of.
in your hospital, what we use?
So we make local solutions there only.
Including what?
So we use the normal saline, cold saline, along with the heparin solution, 1000 unit per 100 ml of the solution, and along with that, mm, uh, yes, sir. So heparin along with yes, sir.
Vasodilator, antioxidant, to use that? No.
No, sir.
Okay. So why perfusion is being done for a kidney transplantation or
Uh,
any solid organ transplantation?
Sir, reperfusion is done with this kind of fluid to prevent if there is any to clear the residual blood from the donor, so that chances of sensitization decreases.
So we want to do a solid organ transplantation. We don't want to do a blood to be inside the organ. So you need to flush it out. Okay. So if you can do it by local made solution, you told about HTK solution. What is HTK stands for?
Uh, um, Sir, I'm forgetting right now.
Some amino acid like histidine,
Statin, yes.
like tryptophan, like ketoglutarate.
Sir.
What they do actually, they prevent the pro-inflammatory, the surge of the inflammatory and pro-inflammatory cytokines, particularly in the disease donor. So they prevent these chemokines to be act on the epithelium, and also the inflammatory response is much less if you use these solutions. Okay.
Yes,
So
sir.
for that you have used in this patient, you are telling that the two arteries, that's why the cold ischemia time was slightly higher, and you use the local solutions, and probably uh, that may be less preventive for ATN and
Yes, sir.
rather than commercial solutions. Okay. Suppose this patient is during a perfusion, there's a blood is inside, you have not cleared it up properly. Okay, and there is a transplantations in between. O blood group is involved, O blood group, and this is a O2B like that.
Yes.
Are you aware of any complication that might happen in a recipient?
Sir, hyperacute rejection may happen.
No, no. Why hyperacute rejection? O blood group is a universal donor. Kidney will be okay, but
O2B, yes.
kidney, O blood group without any inside blood, or O blood group with inside blood. Are they aware of any side effects? Anything? Have you heard the name of a passenger lymphocyte syndrome?
Yes, sir.
That happens. This is like in a graft versus host disease in a solid organ transplantation. So you take this, and patient develops antibodies, and it keeps the patient actually. Okay. Graft versus host disease, does it happen in solid organ transplantation?
Sir, graft versus host disease is commonly seen in hematopoietic stem cell
Why
transplantation.
it doesn't happen in a solid organ transplantation, kidney transplantation especially?
Sir, not really heard of, but not
Why?
common.
Because
Uh,
the organ is only 150 grams.
yes, sir.
Antigenic load is very low.
Yes,
When
sir.
you are giving an allogenic bone marrow or a bone marrow transplantation, your stem cells, a huge amount of antigen body is exposed. So
Yes, sir.
antigenic load is much less. Okay, so patients have a two artery. He has a reperfusion time. Perfusion time was low, and you have put it so that you were thinking that this might be a cause of this graft dysfunction. Okay,
Yes, sir.
so you have once you put the kidney inside the recipient's body and ostomosis declamping is being done, and there is no urine in on the table.
Yes, sir.
Okay, and Eva as a nephrologist has been called in the OT. What will you do?
So first of all, I would like to see if the blood pressures are okay for the patient.
Okay, probably an anesthetist to see that. Okay,
And the volume status of the patient.
you have to do some homework. You just always recheck the two important things. If such catastrophes, to avoid the catastrophes, you check your blood groups of both the recipients and donor once again, and you check your cross match report once again. These two are must. Because if you have a very good infrastructure, there's a multiple checkpoints. But once we will be doing transplantation alone, that can be one important that can cause catastrophe and can cause huge damage to your career. Okay,
Yes, sir.
so that you do that, and after that, you what will you see, want to see and want to do? The surgeons will be telling the blood flow is okay. Well, like close it now. So it's okay. Kidney is looking fine. This is firm, pink, but no urine on the
Uh,
table.
so there is, but the kidney is pink, so perfusion appears to be okay. In that case, we might want to give a trial of diuretics.
You think of the volume status. You'll give some diuretics. If the urine comes, it's fine. If it doesn't come, then it's always better to take a biopsy on the table, because why the biopsy in the immediate post-transplant period is difficult compared to a late post-transplantation period?
Yes, sir.
Because anyway, you have taken the biopsy on third post-operative day.
Yes, sir.
So what is the advantage of taking on the table versus on third post-operative day?
Sir, in third post-op day, if as compared to the on-table biopsy, sir, the organ is in front of us, and there's less likelihood of um, damaging the vascular supply of the kidney,
Hmm.
and lesser chances of introducing the infection uh, when going through the percutaneous route as compared to the open.
So you can
And
always see, you can stop the bleeding on the table, and this is much more easier.
yes,
Okay,
sir.
but the problem is that if you take a biopsy, then in the dialysis should be slightly cautious. You should be doing the dialysis. So, can you name some situations where the biopsy bleed chances are high? One is immediate post-operative period is one.
Yes,
Anything
sir.
for a normal kidney also, native kidney?
Uh, if the patient is on any anticoagulation and by chance
That is
has been
that
missed.
1, 2, 3, 4. This is a side question.
Yes, sir. Sir, low thrombocytopenic state if there is ongoing
You have
sepsis.
excluded the coagulation, you have excluded, but something. If the patient is creatinine of 10, will you do a biopsy?
Yes, sir. Sir, raised creatinine uh, will lead to the platelet dysfunction. Might present
Biopsy
with the.
in a pregnant woman,
Yes, sir.
in a pregnant third trimester biopsy, second trimester, third trimester biopsy. So these are
Sir,
the situation of the bleeding risk is very high.
yes, sir.
Okay. So you have taken a biopsy on the table, you have sent it for something, and your preliminary report has come, probably ATN, and you have taken the patients to your room, transplantation ITU. Hmm? But
Yes,
if
sir.
there is no urine,
Yes, sir.
how will you approach?
Um, So in the patient who is immediately transferred after the transplantation, in trial of diuretics has also been given, patient is volume adequate and still patient is anuric, then we'll have to first of all manage the complications of uremia. For that we can start the patient on the dialysis
Will you
as well
ask,
as
will you ask a sonologist or will you do the Doppler by yourself for the?
Ye- yes sir, ask the sonologist for a Doppler
So
to look for if there is any the anastomosis is okay, to look for the anastomosis.
vascularity of the kidney, whether there is a thrombosis or not.
Yes sir.
If they tell there is a thrombosis and there is no flow inside, then there is an urgent indication for the re-exploration.
Yes sir.
Okay. Suppose the patient is told that yes, there is an arterial thrombosis, and the versus the patient they have told there is a venous thrombosis. So where is the more urgency? Both are absolutely urgent.
Yes sir, both are urgent situations, but for the patient, if the patient is having arterial thrombosis, it is more likely to produce infarcted state in the graft.
So that is a ultimate threat to the graft.
Yes sir.
Okay. If you don't do it, you have to do the nephrectomy because the graft will be lost.
Yes sir.
But if it happens, when does it happen? Usually, the graft arterial thrombosis, the initial
uh,
phases. Okay. Suppose this is your sonologist tell you this is a venous thrombosis. How this is differentiated in the ultrasonography graft arterial thrombosis versus a venous thrombosis?
So venous thrombosis, the graft would be congested, and while in the arterial thrombosis, there will be a decrease in flow on the Doppler, and there will be raised peak systolic velocity, and uh, resistivity index would be increased
Where
to uh, so in the arterial.
arterial stenosis there will be no flow. Stenosis I am not telling. I am telling about thrombosis. Okay, this time is less. So there will be no flow actually, but which one is more? So if there is an arterial thrombosis, there is an urgency, ultimate urgency. You take the patient to the IR room or can be re-explore, rollers can do reanastomosis, everything. Okay,
Yes, sir.
but if they tell there's a venous thrombosis in those situations,
Uh, Sir, in case there is venous thrombosis, we can think of uh, uh, thrombosuction
they
is
will what they
one
will
possible.
tell in a Doppler. They will tell is a reversal of the flow. Blood is going, but there is a reversal of the flow. Okay.
Yes,
And after some time, there will be combination of both arterial and venous. If this is a venous thrombosis, it is more dangerous, and arterial thrombosis is a more dangerous.
sir, arterial thrombosis is more dangerous.
No, if it is a venous thrombosis, then this will be graft will be congested. Sometimes it will swell up. After that, it will rupture.
Yes, sir.
So patient, you can lose the patient. One is threat to graft only, one is threat to life.
Patient.
Okay. So you have to be more. If in the midnight somebody tells that there is a no urine and there is a venous thrombosis, you have to come in the night and whatever you have to do in the night only. For artery, you can wait for 1 hour, 2 hour time.
Yes, sir.
So forget about probably your patient. If I could gather from your history, this patient have probably had delayed graft function and ultimately now has developed probably either a chronic antibody mediated rejection or can plus minus BK virus nephropathy and a graft dysfunction. Okay, so what
Yes,
will
sir.
you do? I'm not going to the pre-transplantation period. So what are you thinking that what might be the pre-transplantation etiology? What are the cause of renal failure for this patient?
Sir, the history is more likely suggestive that the patient in the history,
With hypertension and edema.
so edema developed late in the part of the CKD, so that can present with the CTID also.
So if your any 28 years male comes to your OPD and shows a report of creatinine 3, tell me 1, 2, 3 diagnosis for this 3 creatinine.
Sir, patient presenting with the creatinine of 3, and we have to suspect without any other thing, then first impression could be the chronic glomerulonephritis followed by any sort of followed by CTI, V Kakut, and
At the age
then
of
CTI.
28.
Yes, sir.
If a Kakut happens in age of 20, what kind of Kakut is expected?
So Kakut will usually present early age in the pediatric age
Which
group.
Kakut?
VUR,
VUR. VUR usually develops in reflux nephropathy's age is 18, 20, like that. Okay. At
yes,
28 years, if a Kakut happens, this happens to be maybe a solitary kidney. Okay, maybe a single dysplastic kidney. So this kind of Kakut can happen. Otherwise, it is difficult. Sometimes your partially treated posterior urethral valve. This
yes,
can
sir.
happen at this age.
Yes, sir.
Otherwise, Kakut, this is not the age of Kakut. It's the age of glomerulonephritis. Tell me two glomerulonephritis that happens in 28 years of age and cause renal failure.
Sir, IgA nephropathy,
Yes,
along with that, FSGS
yes,
can also be there.
yes. So have you taken the family history? You didn't mention about any family history. Do you
Yes,
think
sir,
of
no significant family history of renal sickness in any family member.
so you didn't tell that.
Yes.
Is it important? Any genetic disease that can happen at this age, 28 years male?
Sir, familial FSGS usually presents early.
So
Uh,
familial disease.
ADPKD.
ADPKD at the age of 28 years, CKD. So,
Sir, it starts presenting not as a CKD at that time.
okay. So have you asked whether the patient can listen, hear properly or can see properly? Any vision
Yes, the
spectrum
systemic examination was normal, and there is no similar family history which might point out to Alport's disease.
syndrome. So if it all part happen in a 28 years, which kind of genetic Mendelian transmission it is?
X-linked recessive.
Excellent recessive. This is what kind of transmission is oblique transmission. You have to inquire about the maternal family. Okay. So why are you worried about this, knowing these pre-transplant diseases? Is in
Uh,
importance. Someone is worry is recurrence. Okay.
yes,
Other
sir.
than recurrence, why are you worried to know the pre-transplant disease? Tell me some diseases which in which recurrence is not a problem, but something happens more commonly and that is a problem. Post-transplantation period.
Sir, in post-transplantation, there is increased risk of, uh, sir, if the patient is DKD, there is higher chances of other organ system being involved.
If there's ADPKD, suppose, what is
Yes,
the
sir.
chance of
Sir,
post?
if the ADPKD is there leading to the CKD, then there is possibility of cystic dilatation in other systems like hepatic cyst or aneurysmal dilatation in the
Which side effect
brain.
happens more? Does NODAT happens more? PTDM in a
Yes, sir.
polycystic patient?
Yes, sir.
Yes. So like that, if you this is a patient of Alport syndrome and now has a graft dysfunction, so it is not a recurrent disease. What happens if a post-transplantation graft dysfunction happens to a patient of Alport syndrome?
Sir, anti-GBM disease may present in these cases.
So if you do a biopsy, you can get a crescentic gene. That is not a recurrence, but is important. So polycystic disease develops a diabetes. That is not a recurrence, but is definitely problem.
Yes,
Okay,
sir.
like that of hepatitis C associated disease, the PTDM, that is important. Okay, so sometimes it is required not only for the recurrent disease and also for the.
Sequelae.
Okay, so what will you do with this patient now?
Uh, Sir, the patient is already discharged. We need to follow up closely with the renal function, and also the routine urine microscopy has to be evaluated
How,
on the
how
sequential follow.
evaluate the patient so far the kidney dysfunction is concerned? What will you do for that?
Uh, I'm not understanding.
So your creatinine is 1 point. There's a graft dysfunction. You have told 5 etiologies. You have made 5 etiology provisional diagnosis. You have to confirm it now by diagnosis by doing either some tests.
Yes, sir. So for chronic ABMR, we have already done the biopsy, but the renal biopsy was not suggestive of ABMR.
So you have not done biopsy at this point. No? You will do a biopsy. But other
Yes.
than that, if you
Uh,
do a biopsy, what other non-invasive test will you do?
Sir, for CNI toxicity, TAC level has to be checked, which is already normal for the patient. And if biopsy histology is suggestive of TAC toxicity, we can consider decreasing or maybe changing over the immunosuppression.
Okay, one is the TAC level, another
Uh,
antibody testing, any viral screening.
yes, sir.
Hmm?
BK virus for the that BK virus DNA levels we can do if we are suspecting BK viral nephropathy, and accordingly start tapering. If positive, we can start tapering the
Suppose,
immunosuppression.
so what is the treatment threshold for a BK virus nephropathy?
Sir, we start with the decreasing the immunosuppression first by the anti-proliferative agents, mycophenolate, mofetil has to be decreased, and then sequential BK virus levels, BK viral DNA levels has to be repeated.
When you
If
do
it is,
the blood level
yes,
is beyond what?
uh, so 10,000
10,000
copies.
copies per ml. Or
Yes,
there
sir.
is biopsy proven BK virus nephropathy.
Yes, sir.
Or there is a biopsy proven BK
Yes,
virus
sir.
nephropathy. In
Yes,
those
sir. Yes, sir.
situations, yeah.
Or if we can also think when if there is decoy cells in the urine.
So suppose this patient is in the biopsy, you have got this is a CNI toxicity. Chronic CNI toxicity is the biopsy report.
Yes, sir.
Okay, how will you adjust your immunosuppression?
So for chronic CNI toxicity, uh, as per his transplant age, we'll have to keep the CNI levels on the lower side, uh, for like immediate post-transplantation, 10 to 12 nanogram per ml is recommended. So we have to go for the lower threshold for the CN TAC levels.
Yeah, lower threshold and lower blood level. So what can be done for this patient if this is chronic CNI toxicity? There is no rejection now, and there is a quite significant amount of IFTA is there. Okay,
Yes, sir. We can consider, sir, switching from CNI to mTOR inhibitors.
CNI to mTOR inhibitor. Okay, so which mTOR inhibitor?
Sir, everolimus. Initially, sirolimus was used, but sirolimus is used in studies, but sirolimus is not as of available. Everolimus we can use.
But you want to convert CNI to mTOR inhibitor. So is that beneficial or some there is a more rejection and the lesser
Uh,
frequency that is okay, but more rejection is
so
not
rejection risk is higher, but the nephrotoxicity from the CNI is decreased.
that will raise, but you lose the graft. Okay,
Yes, sir.
lose the graft, will be less cancer and might be some CNI levels in the biopsy, CNI toxicity evidences will be less, but it ultimately lose the graft.
Yes,
So
sir.
you should not convert from CNI to mTOR inhibitor. What is the name of trial?
Uh, ben, ben, uh,
The convert. I have told you.
convert trial. Yes, sir. Convert trial.
Yes. So this is not an option now. So what is an option?
Mm. Belantus.
You can use a belatacept. Yes.
Yes. Yes, sir.
Yes. So
Uh,
you want to get benefited from giving belatacept for this patient. He
yes,
is
sir.
not on CNI.
Yes, sir. We
So
can use Belantus.
so
Yes, sir.
how do you do that? The patient is on maintenance CNI. Suppose tacrolimus is on maintenance tacrolimus. You want to shift it to belatacept now? What is the
Sir,
advantage and how
overlap.
to do that?
Sir, overlapping has to be done for both the drugs,
How much
and
overlapping and how will you do that practically?
uh, sir, I don't know.
So you have to be at least you normally you give this belatacept for a maintenance phase, you give once in a month.
Yes, sir.
Okay. But you have to be there is a 5 dosage at a 2 weeks interval. You read it. In a 2 weeks, you give 5 doses, 5 gram, 5 gram, 5 gram, 5 gram, 5 gram, like that. With a 5 dosage, and at this 5 weeks time, you should gradually taper off your tacrolimus. Initially full dose, then you make it half dose, make it 25% dose, then you remove it.
Yes, sir.
Okay. Then you continue your monthly belatacept that will cause lesser fibrosis. You get rid of this CNI toxicity, but we may have a more rejection, but ultimately graft function will be stable.
Yes, sir.
Huh? Who has
Yes.
described this benefit?
Benefit.
Yes, it is a benefit trial.
Yes,
Okay.
sir.
So another option for this patient, you can do it. But there is an increase if you do a belatacept. What increases? Which side effect will be more?
Uh, Risk of rejection.
Risk of rejection will be more, okay, but ACR will be more, but the graft will be stable.
Yes, sir.
Any side effects? It's a non-graft related. So chances of some cancers or some lymphoproliferative disease will be high.
Yes, sir.
So if you use mTOR inhibitor, your cancer risk will be low, but if you use belatacept, your PTLD risk will be higher.
Yes, sir.
Okay. But still, it's a possibility. But you can
Yes, sir.
always decrease your CNI dose. You can increase your MMF dose.
Yes, sir.
Okay. And you can get a good symphony. Who told that?
Uh,
Which?
Symphony light.
Yes, this is a light symphony trial. They told that if you reduce the CNI dose, you give a good amount of the MMF dose, you give a steroid along with that. If you compare to anything, it will be a good result. Okay.
Yes, sir.
So we have had 3 trials: convert trial, elite symphony trial, and benefit trial. So we may
Yes, sir.
continue with this. I think we are very late. We can take another class for that. So
Yes.
ultimately now what is your diagnosis? Tell me in one line, then we'll finish.
Sir, my diagnosis would be uh, hypertension, CKD stage 5, post-transplant, native kidney disease likely to
So
be
after the discussion in which bullets you are not agreeing now after all the discussion?
TTID. I'm not agreeing in my presentation, sir. It should be CGN, and early ABMR is fine, AGA5 is fine, and the probable diagnosis would be pre-renal, but secondary to chronic allograft nephropathy more likely. Chronic ABMR due to the chronic ABMR or VK virus or CNI toxicity.
Just one thing, the donor is a father who have repeatedly told that mismatch is not known. What kind of mismatch you expect with the father?
Uh, Sir, three match would be there, so it can be either uh, uh,
For with a father, how much is a match for any son? Father to son, how much is the mismatch?
sir, at least three match would be there. Three mismatch would be
Match. Suppose A, B, D are in 3 out of 6, you tell 3 should be matched. Supposing
at
A,
least.
2 matching, B, 1 matching, and rest are not matched. Is it okay with you?
No.
No. It's not 50%, it's a haplo match. In each segment, you need to have a 50% match. A
Yes.
50%, B 50%, DR 50%, DP, DQ, whatever, B 50%. So with the
Yes.
father, there is always a 50% or a haplo match. If it is more than that, they can think of a consanguineous marriage or can be a local community or maybe a extended consanguinity like that.
Yes,
Okay.
sir.
And if it is a less than haplo match, then is a disputed paternity. Okay. So they don't tell that mismatch is not known. You always know father's mismatch will be 50%.
Yes, sir.
So I think we can, it's late already, so we can close the discussion now, and Anirudh may take the things, and there will be OSCE sessions. Okay.
Yes, sir.
Anirudh.
Hello. Is the screen visible?
Yes, sir.
Full screen.
Okay. Okay. So this is your good evening, Dr. Ajitesh. We'll start your OSCE session.
Yes, sir.
You'll be getting some images and a few related questions, and then we'll discuss on them. Okay. And this is unrelated to your topic.
Yes, sir.
So please go through the question.
Yes, sir.
Yeah. Okay. So these are the findings of the patient.
Yes, sir.
So with this, what is the provisional diagnosis you have?
So my provisional diagnosis in this case would be, first provisional should be FSGS or MCD.
I mean, it's a syndromic diagnosis would be an adult onset nephrotic
Syndromic would
syndrome.
be adult onset nephrotic syndrome.
Nephrotic syndrome. Do you want any additional investigations to be done?
Um, no, sir. RBCs are not there. Urine is not active. Only proteinuria is there. 24-hour is nephrotic and proteinuria. Albumin is hypoalbuminemic. Thyroid function. TSH is also raised. I
So
think
you
we,
straightforward proceed for a biopsy.
yes, cholesterol, lipid profile we can do.
Okay. So, okay. So this is the biopsy. Can you identify the lesion?
Uh,
Can you identify the stain and the lesion?
uh, Sir, this is pass.
This is pus. The
Yes, sir. Yes.
basement membranes are usually pink
Pink. Yes,
in
sir.
pus. So this is a hematoxylin eosin stain.
Actually.
Yeah. This is a HNE with the lesion. Can you identify the type of the lesion?
Um, Sir, um, FSGS, it looks like.
Yeah, it's an okay. This is an FSGS. So this is the enlarged view. Can you identify the type of FSGS from this? What is the most common variant?
Uh, Tip.
Usually, okay. So we'll come back to the answers. So from the lesions, again, have a look at this and can you identify what particular structures are being seen in this, what I have highlighted? Can you name them?
Uh,
Can you name the appearance?
Sir, in the picture that you're showing, there is focal segmental involvement of the glomerulus, and the Bowman's space is little obliterated, sir.
Yeah, so if you have a look on this side and this side, if you compare the Bowman spaces in both these sides, there is something very distinctly different.
Yes.
On the side which is glomerulosclerosis, where you have the sclerosis, there is something else coming up. Do you know what are these?
Uh, Spikes.
Okay, so we'll come to the answers. And this was the IF, which shows IgM. Can you describe the type of or the pattern of the pattern in the immunofluorescence?
Uh, Sir, diffuse patchy involvement, inter patchy involvement of the IG, the immunofluorescence. uh, like up to grade 2 plus, not very bright.
So it's a small, fine, granular, brushy kind of a picture. So this is the electron microscopy. So what do you see in this particular electron microscopy, and how can it help you in identifying the etiology?
So I think I can see is podocyte flattening is there, food process flattening is there,
Other,
and if
other,
yes
other
sir,
food, can you identify the food processes? So
yes
are
sir.
they effaced completely?
So not completely effaced. Some in the whole of the visualized section, some parts are not effaced, but patchy effacement is there. Not segmental effacement is there.
Okay. So does it help you in identifying the etiology?
Uh, so segmental effacement more likely points towards FSGS only.
Okay. So before we proceed further, this particular is a no specific, not otherwise specific, but the NOS variant. Okay. And this is known as the cobblestone appearance. Basically, there is hypertrophy of the visceral epithelial cells, especially on the side which is getting glomerulosclerosed, and they come up and appear. They are very common in the cellular variant as well as in the variants which are that is the NOS variants. And so how will you treat this patient? So you have a patient, 20-year-old male with FSGS, NOS variant, who has full florid nephrotic syndrome. How will you treat him?
So the patient presenting with the NOS variant of FSGS with full flared nephrotic syndrome, we can start with the if the patient is not having any renal dysfunction, creatinine we could see 1.1, and in that case we can start with the oral steroids. But if the patient has acute dysfunction or severe nephrotic syndrome in the form of severe edema and other volume related side effects, then we can give the 3 doses, or MP's pulse can be given. But for if no other side effects or no effects are noted, then we can start with the 1 mkd prednisolone.
Okay. So how long you will wait for to look at the response? How long will
So
you wait
for
for it?
4 months, 1 mkd has to be given to say that it is not effective.
Okay. So probably you treated him for that particular period, and now this is the results. Uh, so how will you plan further?
Sir, the patient is from 6.7 gram has become 5.1 gram. So we can label it as resistant to prednisolone. So we can consider start tapering the steroid, and then start the steroid sparing regimen, or we can other methods we can use, like for this patient we can consider CNIs, or also the patient is adult, and I mean we can in pediatric we can use cyclophosphamide. But the patient is in reproductive age group, so we should not uh, consider about that. We can consider, but after discussing with the patient. And CNIs we can use, we can go for rituximab pulses.
Okay. So the alternatives for SRNS primarily are the CNIs and subsequently other forms of immunosuppressants. So in a patient who is adult at 20 years of age and has a primary SRNS, do you want to evaluate him further with anything else?
Yes,
What
so
will you do?
for he should be tested for genetic variants, genetic forms of the
What kind of genetic testings are done?
so for genetic testing, we can go for whole exome sequencing.
Okay. So this was a whole genome sequencing which was done, and what do you see?
Sir, the patient has LMX1B variant and significance is uncertain about it.
So how would you infer from this particular report regarding the further treatment in this patient?
Sir, as per this report, no significant variant could be found in the patient. And so
How would you
genetic,
treat VUSS in this particular field?
uh, sir, what?
VUS means this is uncertain significance. That's called a variant of uncertain significance. You have a patient who is phenotypically a steroid-resistant nephrotic syndrome, and you have a genetic mutation available, but that variation is given as an uncertain significance.
Yes.
So how would you take or treat a variant of uncertain significance in this particular clinical picture? Would you further treat him? Would you abort treating it? Any idea?
So patient has to be treated with alternative regimens.
Okay. Yeah, so basically, if you have pathogenic mutations, then probably aborting treatment can be helpful because genetic FSGSs, because immunosuppressants are mainly recommended for primary primary FSGSs. For genetic FSGSs, especially if you have VUS, you can try alternative immunosuppressants with for a limited period, and then you have to check the response, and then you can take a call because it has to be individualized. It cannot
Yes.
be a uniform decision.
Yes.
So, are there any specific treatments for genetic variants of FSGS? Do any genetic variants of FSGS respond to any kind of medical therapy apart from the standard antiproteinuric regimens?
Sir, usually genetic variants are less responsive to this immunosuppressive therapy, and only standard antiproteinuric measures are the treatment modality. And if the proteinuria is uncontrollable, we can consider for medical nephrectomy if the condition goes refractory.
Yeah, but there are certain mutations, like there are 5 to 6 autosomal recessive mutations which are responsive to steroids, partially responsive to steroids. There are a few mutations again which have shown they are responsive to rituximab as well, but mainly when they are in VUS formats. And secondly, the mutations in mitochondrial genes, like the coenzyme Q deficient mitochondrial gene mutation, which results in FSGS. Again, the disease is treated with coenzyme Q supplement that responses, and the proteinuria reduces with that. And when you have a mutation in the QBLin gene, that is again responsive to vitamin B12 supplementation. And the other mutations, there are a few mutations which can be responsive to certain other drugs like anti-oligonucleotide drugs which are in trial. So apart from, mainly obviously most of them only require anti-proteinurics, they don't have any specific treatments. So coming to the last question for this particular case, like whenever these patients develop ESRD, what is the possibility of a recurrence for genetic FSGSs? Is
So
recurrence possible?
genetic FSGS post-transplantation do better, and they have very less chances of recurrence.
Mm. Are there any mutations which are known to recur?
Uh, I've
They are
heard.
rare, but there are mutations. Do you know any specific
I don't
mutations?
recall, sir. I don't
So
recall.
NPHS2 mutation is known to give small amount of recurrences, and most common is NPHS1. If transplanted, then antinephrin antibodies are known to cause post-transplant recurrences, early onset post-transplant recurrences in cases of NPHS1 mutation related FSGSs, which are undergoing transplant. This antinephrin antibodies is pretty important because it's come up as a it's like the antigens which we have discovered in membranous. We have discovered this antibody for MCDs and FSGSs.
Yes, sir.
So just to discuss what we had gone through, that whenever we get an FSGS lesion on the kidney biopsy, you have to find out whether it's a primary or a secondary. It depends on the nature and the clinical picture, and accordingly you decide on the treatment. So mainly the primary variants are treated with corticosteroids. According to the response to corticosteroids, you can plan if calcineurin inhibitors are required or not. If a patient has a contraindication to corticosteroid from the first hand, calcineurin can be used in the first line therapy as well. And whenever you are getting other causes like the secondary FSGSs, you have to find out the secondary causes and you have to treat them. So when do we do a genetic evaluation for a patient of FSGS? Mainly when a patient has come with nephrotic syndrome, you know it's a full-blown nephrotic syndrome, and we have done a electron microscopy, which you correctly identified that that particular image had segmental food process effacement. So usually the primary or the first line steroid sensitive variants normally have or the primary FSGS have a diffuse food process effacement in which more than 80% of the food processes are effaced, and the secondary variants or the genetic variants usually tend to have a segmental food process effacement, so it is less than 80%. So if you get them, then you have to consider for genetic testing, like in our case. And if you get in patients of FSGS, that you have a FSGS lesion in kidney biopsy, but the patient doesn't have any nephrotic syndrome, but the food process effacement is more than 80%, then you always have to consider for genetic testing. And if they are segmental, then you have to work out more on maladaptive causes. Again, the benefit, this we have discussed mainly, that the benefit is identifying the family through the family history. It can help you to spare the patient the cost of immunosuppressants, so that if you get a primary genetic disease, then you would not go very aggressive on the immunosuppressants. Obviously, it gives you an idea for transplantation and as well as for the prognostication, how the course of the patient will be. So this image is important per se, that how would you differentiate primary genetic as well as maladaptive FSGSs. And FGGS is basically the focal global glomerulosclerosis. So mainly the in primary FSGS, glomerulomegaly is uncommon and the food process effacement is diffuse. Genetic, you don't usually get glomerulomegaly. Glomerulomegaly is mainly associated with the maladaptive one, and in maladaptive one mainly you have the perihilar variants. There are only one or two genetic mutations which can have perihilar variants associated, but the perihilar variants in genetic don't have glomerulomegaly associated with them. So, and through them you usually get segmental food process effacement. So this food process effacement, like the one we were describing, so this image actually shows a type of a complete effacement of the food processes, where you see that there is no other food process associated, only except for one or two lesions. And whereas in this particular lesion, you would see majority of the food processes are intact. And the average food process width in all the three variants. And if you look at the genetic prevalence in a patient of 20 years, so what it tells is that in essence, that whenever you are evaluating a patient with primary steroid resistant FSGS, the chances of getting genetic mutations is higher whenever the patients are younger. So as the age goes up, the chances of getting genetic mutations associated is lesser and lesser, and most commonly when they are above 18, the like INF2 and COL-A4, they are the most common mutations which are associated. Whereas in the young age congenital variants, NPHS1, NPHS2 are mainly the most common one. And based on this, you can again stratify your patients and plan for further therapies. So these are the mutations. We described the relapses associated with NEF1 and 2. So this is your last question. Please have a look.
Will that it? Yes, sir.
Okay. So he was found to have some renal dysfunction. The renal dysfunction is as described. Please have a look. And can you tell me what is unusual about it?
Kidney size is enlarged.
Yeah.
And otherwise it appeared, and the urine has RBCs also. So yes, sir. So I mean,
So with this, you did a biopsy in this patient, and this is the type of lesion you are seeing. So can you identify the type of lesion?
uh, Membranous.
No, this is not
Nephropathy.
membranous. Are you
Yes.
able to see the capillary tufts all together?
Yeah. No, sir.
What is it?
CRBs.
So in majority of the area, in the majority of the glomerulus, the tufts have collapsed. This is a collapsing esophagus.
Yes, sir.
Okay. So what is this particular, what does this image show and what I have highlighted? Can you identify with the clinical background which I have given? That a young African boy who is a drug abuser has a 13-gram proteinuria and has enlarged kidneys and has a biopsy in which we are seeing this. Can you identify what is this and what is the significance?
This is amyloid deposition.
What?
Sir, amyloid deposition.
Not really. He's a young fellow, no? So
Yes, sir.
he's a young fellow with a 13-gram proteinuria. And when you give a history of an African and IV drug abuser, we usually think about
Collapsing
ischemic.
FS.
Yeah.
Yes.
So this is an image that shows a microcystic dilatation of the tubule, which is a very common hallmark of collapsing FSGSs, which are associated with which disease?
Hewan.
Yeah, Hyvan. So this is a proteinaceous dilatation of microcystic dilatation of the tubule, which again is the result which causes the kidney size to enlarge to that.
Yes.
So can you identify this structure which I've highlighted in the EM?
No, sir.
So again, this is a hallmark which you see in a Hyvan or any kind of interferon mediated changes in the EM, that is a tubular reticular inclusion bodies, TRIs.
Yes,
Okay.
sir.
So we have just described the cause. So we started the patient on therapy. So are there any genetic diseases or genetic mutations which increase its susceptibility?
APOL1 gene.
Okay, very good. So from APOL1 gene, in that particular patient, another family member was found to have a renal dysfunction where he was hypertensive and his creatinine was 2.5 and he had proteinuria in his RBCs. Proteinuria is 3 plus proteinuria in his urine. So considering the family history, do you need to evaluate that patient also for genetic mutation?
Yes, sir.
Yeah, for APOL1 you would do. So for a patient who suppose he came out to be positive, so are there any therapies? So I am highlighting a possible potential therapeutic agent which I have highlighted in this diagram. Can you name this particular agent or the drug which came out for this and its site of action for APOL1 mutation? It came out just a few years back, 23 probably. The trial was completed. So
I have read but not recalling.
okay,
And
so it's for APOL1 mutation. Okay, so this completes your question. I'll just briefly describe APOL1 for you. And for APOL1, mainly it's a high risk phenotype which increases the possibilities of kidney failure in the patients who have the high risk variants. And APOL1 actually came as a survival benefit for patients from sub-Saharan Africa, where you have the African sleeping sickness. So mainly the variants, the APOL1, the wild type variant used to protect the patient from the common variant of Trypanosoma brucei. But you have certain resistant factors like the serum resistant antigen binding proteins, which were secreted by rhodesians and gambienses. So to overcome that, this subsequent mutation or the high risk variants of G1 and G2 came in which G1 and G2 have a specific binder protein which binds to this particular resistance contributing factor known as the SRA, so that these rhodesienses or these variants or this particular type of trypanosomas again became susceptible in these patients. So these high risk variants over time got genetically selected, and as because it was a much more late onset mutation which was seen in the humans, because the earliest humans are actually migrated from Africa, and this mutation actually came up later in the last 10,000 years. So that's why in the initial population surge which migrated towards Asia and everything, in these population, the Asian population, you don't get this particular mutation. Although the entire humanity or something which came up and migrated from Africa, the subsequent last 10,000 years, as because this particular mutation was favored. So in the later years, when there was a slave trade and these population, the later onset, this later population which migrated towards the Africa to the Americas, South and North both. So you commonly get all these mutations at that particular point of time. So these are the sites where this can you just yeah, so these are the sites where you commonly get these mutations, and we have again described this serum resistant associated binding protein, which again gives you the susceptibility. So the mechanism of causing this particular for causing renal damage in this particular mutation is that it causes iron fluxes, it causes mitochondrial toxicity and causes increased stress to endoplasmic reticulums, as well as there is increased IL-1 and IL-8 transcription, and there is reorganization of the podocytes. So normally only having ApoL1 is not sufficient. You need to have other environmental factors which act as second hit. And this ApoL1 actually, which was supposed to have a protective trajectory, because of the presence of it, usually you have multiple implications all throughout the life of the patient, that it confers increased risk to preeclampsia, preterm birth, as well as increases risk of ESKD in patients with sickle cell disease. In lupus patients who are known to have ApoL1, there is a higher possibility of much more severe variant. COVID and HIV, in both these cases, the ApoL1 mutation confers higher risk of ESKD and worsening progress of renal diseases. It also confers risk of dyslipidemia as well as cardiovascular mortality and morbidity, and also in the end result increases the incidences of kidney diseases. So if you look at the spectrum of the kidney diseases or the ApoL nephropathy, it compares, or it actually is the amalgamation of multiple diseases, only except the most important thing, that the diabetic diseases are not particularly influenced by the presence of ApoL1, but hypertensive diseases on the other hand are significantly affected, and there is a very high risk of ESRD in hypertensive patients with ApoL1 mutation. The other diseases are like the HI1 and interferon associated diseases which we described. So if you look at the collapsing glomerulopathy from the picture of ApoL1, so mainly the patients who have ApoL1 have collapsing FSGS in presence of infection, drugs, or autoimmune diseases. And the patients who don't have ApoL1 mainly have ischemic or vascular diseases which result in collapsing FSGS. So as we described, multiple infections, autoimmune diseases are associated with it, as well as drugs and malignancies like multiple myeloma are associated in the incidence of collapsing FSGS. In the non-ApoL1, mainly TMA or the ischemic vascular causes, as well as certain genetic diseases are commonly associated with that, and crystalline podocytopathy, which is a type of monoclonal gammopathy, can also be associated in non-ApoL1 mediated collapsing glomerulopathy. In African population, the incidence of the fact of presence of ApoL1 confers very high risk of renal dysfunction. It was shown in multiple studies, and there are a couple of variants which are associated with the M1 modifier gene, again which has a comparatively better or protective role in patients with ApoL1. So this ApoL1 again gives a higher risk of AKI in patients with COVID as well. So genetic testing is important in patients who, especially of African origin, who have FSGS or SRNS, who have a ESKD of unknown origin, and in patients who are going to be donors, and in other CKD patients with potential involvement. Because why do we need to look at donors for this? Because like in this patient, if the patient which we described, if that particular patient undergoes a renal transplantation in a patient with ApoL is not that of a high risk, but from a patient who carries an ApoL gene, even with one risk allele, the graft survival is reduced. With two high risk alleles, the graft survival in APOL1 carrying patients is significantly reduced. So coming to the therapeutic targets for APOL1, which you were describing, is inaxaplin. Inaxaplin is a newer molecule. It's a small molecular drug which has come up to block the APOL1, because APOL1 actually acts as a channel. It like acts as a cationic channel and increases the ionic flux within the podocytes. And this channel, particularly over the mitochondrial body as well as in the in the cell surface of the podocyte, it's blocked by inaxaplin, and thus it actually reduces the proteinuria as well as renal disease progression. Other drugs which are in trial like baricitinib and this AZD2373 is the oligonucleotide or the silencing RNA. And this recent trial which was conducted on APOL1 variants, in that it actually showed there was significant reduction in the proteinuria as well as reduction in the UPCR over a 13-week period. And this was a phase 2 trial known as Justice trial, which showed there was safety in using baricitinib, but again, its clinical efficacy is yet to be tried. It's not completely out. So with this, we'll finish. Okay. Thank you, Dr. Jitesh.
Thanks.
I think we are a bit late. We can finish the session. Prajitesh, you have done reasonably well. Just have to be slightly more, reflex should be slightly more strong, and
Yes.
you should understand what the examiner actually asking you, what he wants to know. Otherwise,
Yes.
preparation is good.
Thank you.
So over to Mr. Shourov to conclude the session.
Thank you very much for presenting us with this invaluable session, and really grateful to have your presence in spite of having the very busy schedule. Thank you, Dr. Aniruddha, for beautiful OSCE session, and thank you, Dr. Ajitesh, for being a very fruitful discussant over here. And I would like to thank Mr. Sai, Mr. Amol, and InterCCT family for being with us and inviting all the participants. And sir, I just have had contacted Dr. Santosh Barugis. I think that, maybe in the month of March, kindly let us know in the first week if we can have this another classroom. So we can discuss it offline. Thank you very much once again, and looking forward to catch you in the next classes. Thank you very much, sir. Thank you very much once again. Good night. Take care.
Good night, sir. Thank you, sir.
Thank you. Sai, you can